Then.
All right. Okay. So, okay.
Completely screwed this up.
I think we're good. I'm going to assume everyone can hear me. Speak up if you can't hear me. So my name's Ben Burton, or Dr. Burton. Hold on one second. Heather, you look like everything's going wrong. Is everything okay?
I don't think I've made you the host yet. So let me
Let me see really quick. Oh, no, I can't share my screen yet.
Okay. All right. Hang on. Let me do that. Oops. Everything's moving really fast. So if I don't click really fast, I click on the wrong thing. Okay, here we go.
While you're doing that, I'll kind of just give myself an intro and just let me know when you're ready for me to pop up the slideshow. So I really appreciate what Heather was saying. So I'm a physician, but I understand that I'm not part of the community of hypermobility organically. It's not something that's affected me personally. And most of the interactions that I have, I'm always sitting in the physician chair. So as I start to speak, if I say something that seems wrong or you want to disagree with me, I'm very open to that. And you can kind of correct that. And I'm interested in making this interaction between physicians and providers and patients much more productive. And I'm hopeful that that's sort of what we accomplished today. And I understand that everyone's input here can be really helpful for that. So if there's something you want to say, feel free to chime in. And I promise I won't be offended. There's nothing you can say to me that will hurt my feelings more than what has already been said during my medical training. So that's just sort of the preface, everything that I wanted to talk about really quick. And I think I now can share my screen. So I'm going to do that. I have this slideshow. While I'm doing the slideshow, I will be looking at the slideshow. So if there's something that you'd like to chime in and say, you may have to do it audibly so I can hear you. All right, and we will get started. So this is just making the most of your time with the doctor. And this is something that's really kind of interesting to me because the patient-doctor dynamic is almost adversarial from the beginning. You have a patient who's been waiting months for an appointment, stressed about the financials that have to do with this appointment. They're often sort of playing doctor roulette to see if this doctor is going to pay attention to what's going on. And there's a lot of anxiety on the patient's end already coming in. And then you have a doctor who, depending on what's going on that day, may be already stressed. Most of the time we're behind by the second hour of the day. There's a lot of stressors and a lot of things going on our end. And then we put these two people in a room together to try to solve a very complicated problem in a very short amount of time. And it's often a disaster. So I wanted to kind of talk through that and how some of these patient interactions maybe can be a little bit more productive. And again, I'm really open to feedback as I do this. So we'll go ahead and get started. So there's an interesting thing. When I was a resident, we used to talk about what makes a good patient, and good in quotation marks. And this is very arbitrary. And it was sort of like if you were to ask a doctor on a panel of patients to just point out their good ones, these are the things that they would point at. And I think all of us, these conscious things, I think we're all aware of that. And I think most of us strive to have these sort of attributes in all of our human interactions. And I don't think that's anything that any patients, particularly struggle with. The subconscious part of what makes a doctor think a patient is good, though, is actually kind of interesting. When you really drill down, when doctors are picking out patients that they think are good, well, it's usually a patient that has a disorder that the doctor is familiar with. It's usually the doctor is familiar with how to treat the disorder, and then generally the patient is responding to that disorder or responding to that treatment. And this is really frustrating for people that have complicated or rare disorders. Because you're already almost starting behind the gun because this doctor has this subconscious stress about treating you as a patient. Now, why is there subconscious bias where doctors think patients that are complicated or that have rare diseases they're not familiar with aren't, quotation marks, good? And the big problem is a doctor's expectation of themselves, and this is getting better, but historically very much has been perfection. Doctors don't make mistakes. And when we make mistakes, and especially when we make mistakes in training, we are severely punished for that. And when we make mistakes in practice, it can cost us our career. And depending on the severity of those mistakes. So there's a lot of stress when we enter into a patient-doctor relationship if we aren't confident in our ability to perform perfectly with that patient. And oftentimes that stress and that discomfort translates and is directed squarely at the patient like it's your fault. And it's really unfair. But it is the reality of what's sort of happening sometimes in these interactions. So kind of the first step, and this is something that, you know, on my end as clinicians, that we're starting to understand and we're trying to unpack and we're trying to be better about this. But this is something where you're already sort of starting a little few steps behind when you have a condition like hypermobility, because not a lot of doctors are very well informed about it. So I wanted to unpack this a little bit and how to make this better, because when you have an uncomfortable doctor and then you put that with a complicated patient, you have a big waste of time. The patient doesn't get what they want. The doctor usually is not very helpful, and it's frustrating. And it's unfortunately the person that suffers the most is the patient. So I want to give a little disclaimer about the rest of this really quick, okay? This is not the fault of a complicated patient. I am not saying that at all. And it is unfair, and I recognize that, to ask a complicated patient, in addition to everything else that you're already trying to manage, to also take on this deficiency of a doctor. But we're trying to get better, but we're not there yet. It's just the reality of what's going on. And these are some tools that I found that seem to help if the patient has these tools in their tool belt going in. A big part of what my wife and I are trying to figure out is patient advocacy and how to improve these patient-doctor interactions. And while I would love to be in front of doctors and telling them what to do, that's not a role I have found myself in to a large degree yet. Most of the time when I do this sort of trying to improve that interaction, it's on an individual basis with patients. So here are some tips as we go through this. And now before I move forward, I've said some kind of big and maybe some uncomfortable things. And I just want to pause and make sure nobody wants to correct me or voice any concerns or any thoughts about any of that. I can pause for a second to receive any of that if anyone wants to speak up. Okay, I think we're good. So let me go into the tips. So I think one of the biggest things to do when you go in and see a provider, especially for the first time, but even if it's a provider you're very familiar with, is have a plan for that appointment. Like, what is your goal? What do you want to accomplish during that appointment? And classically, what happens is the patient comes in, tells the provider their symptoms, the provider figures out what the diagnosis is, and then the provider provides a treatment plan for it. Now, that starts to break down when we're dealing with chronic disease or chronic conditions. And so a patient comes in and they have symptoms, perhaps we already know the diagnosis, or they come in and they have symptoms and we don't know the diagnosis. And so it's important when we start to vary from this sort of urgent care, you know, I have a UTI type encounter, to more of a chronic disease management encounter or chronic condition management encounter, that we figure out exactly what it is that you want to accomplish during that appointment. And some of the big things, there's a lot of things that you can do in that appointment, but these are sort of, in my opinion, sort of like the 4 big things that people really want to accomplish when they come in and see their provider. You either want to get a diagnosis for the symptoms that you're experiencing. You want to get some specific testing done because you think it can help forward your diagnosis or your treatment plan. Or you kind of have an idea of what's going on and you want to try some new treatments or diagnoses that perhaps people have read about or learned about, and they want to try to engage with their doctor on that. Or they just want their doctor to provide some new treatment plan because whatever they're doing at this moment isn't working. Or they want to get a referral to a specialist to manage this. And there's a lot of barriers that patients hit when they try to accomplish any of these things, especially if it's for a condition a provider is not very familiar with. So I want to give some tips on how to break down each one of these things. But I think first, before you go into that appointment, you can go into an appointment with a myriad of symptoms. And there's a lot of patients, and I'm not, of every chronic condition category that are just have no idea what's going on. They have a ton of symptoms, nothing's working. They show up to the doctor, and all you can do is just sort of unload all of that. And I get that should happen and can happen and does happen, and that's fine when it does happen. But if you have the ability in the moment, if you're in a place where you can, before you go into that appointment, figure out what is it that I want to get out of this appointment today, then that kind of helps sort of set the stage for everything else that you want to do for the rest of that appointment. And you can walk in and very specifically kind of start and be like, I have, this concern, and I'm interested in accomplishing this to solve it. So let's talk about symptoms. And this is maybe the hardest part of communicating with a clinician. There are symptoms that are really important, and there are symptoms that don't change much. And, when we start medical school, when we take a history from a patient, it can take us a half an hour to sort of glean all of the important information that we know what to do with somebody. And then once you get into 10 years of practice, if everything's straightforward, you can get a history in under a minute, because you kind of know what to ask and what to look for. But that's if you know what to ask and you know what to look for. So if a patient comes in with sort of a new array of symptoms that a provider isn't familiar with, things start to break down a little bit. And a lot of times the provider has some very specific questions they want to ask about specific symptoms. And then also the patient has a story to tell about what's going on. And you find yourselves sort of competing for the talking stick, to communicate what's going on with as a patient. Some things that I found that are really helpful, because especially if you're going in with a provider for the first time, this moment of trying to capture what symptoms you're having can be very anxiety provoking. You have all these things in your head that you want to talk about, and you're just worried it's not going to all get out there. And it is not wrong to just write down your symptoms before you go into this appointment and hand that to the doctor and just be like, I am feeling this. Doctors should be, and generally are, pretty good at ascertaining information and absorbing information from written materials. And so if you feel like you're going to forget something, if you feel like you're going to regret that moment, it's not a bad idea to write these things down. Now, that doctor is going to get these lists of symptoms, and they may or may not know what to do with all of it. What we try to do is we try to look at these lists of symptoms, and we try to find what we call a keystone diagnosis, a diagnosis that's going to pull everything together. Now, when you have a complicated condition, when you have multiple conditions, this becomes impossible. And so as a provider, and maybe some of you have experienced this, I know that I've seen other patients experience this, and I know as a provider, I've been on the other end of it. You can get very overwhelmed by the list of symptoms. If you're a patient with hypermobility, there's this pattern of pain that's very hard to describe. Usually there's a component, I shouldn't say usually, often there's a component of depression and anxiety. There's often a component of dysautonomia. There's often a component of being hypersensitive to things. There's often GI complaints. It's just almost every organ system is affected. And as a provider, we get this list, and we're sort of overwhelmed. And so in this moment, and this isn't your job, and it shouldn't be your job, and we're trying to get better as providers, but if you see your provider sort of get kind of wide-eyed and overwhelmed with everything that's going together, it's not wrong to just say, I understand this is a lie. Maybe you can look for a pattern here you pick up on, and we could start addressing some of these symptoms. So you could ask them these questions that I have here, like, could we start by addressing just some of these symptoms, perhaps not all of them? I understand if we can't do all of them today. Or do you see a pattern in some of these symptoms that seems to stand out to you, but not all of the symptoms? And also telling the provider, I understand I may have multiple conditions to consider. So can we just start with evaluating for some of these symptoms? And then, as a provider, that takes off a lot of relief, rather than in the moment having to evaluate and treat, you know, your skeletal system, your GI system, your mental health, and your immune system for your hypersensitivity, we can sort of focus in on one thing and we can really do a good job on that one thing. Now, of course, if this is appropriate in the moment, I understand that I'm generalizing a lot, but these are some things that you can try to do as you're trying to tell your provider all of the different symptoms. So that's just briefly something that you can do with symptoms. So just to recap, have a goal during the appointment. And if that goal is to better understand your symptoms, then you can try to write down all of your symptoms before you go in and help the provider sort of unwind it with them. So the next thing is how to get testing done. So this is the issue, okay?
Correct. No,
Oh yeah, okay, great.
I think there's someone in the waiting room.
Oh, is there? Okay, so chat security. Oh, 6 people. Shoot, I was not paying attention. Okay, so admit all.
Hard to do both.
Gotcha. I see where that pops up on my screen now. Okay, so they're all joining now. All right. Welcome everyone that just got here. My name is Dr. Burton. We're just going through some tips and tricks on making the most of your time with a clinician. And recapping really quick, it's not a bad idea to set a goal for the appointment. And then if that goal is to figure out symptoms, it's not a bad idea to write down those symptoms and hand it to the provider. So here's the next issue. Oh, and also, if you just joined, if you wouldn't mind muting, but if you do have any questions or you want to bring anything up, I do hope this can be somewhat conversational. Feel free to interrupt me. Feel free to correct me. When we'll just keep moving forward. So if your goal during an appointment is to get some specific testing done, here's the issue that you're running into with your provider, what's going on in our heads. So every test that is ordered with the clinician, they are obligated, like our license on the line, obligated to interpret and respond to those labs. We can't just sort of blindly order labs. Once our name is on it, we're responsible for reacting to whatever information comes back to us. So when I'm ordering labs and I'm unfamiliar with what the labs are, it can be very intimidating for me. And then here's the other really interesting thing. And I think this is something that I hope not a lot of you have experienced, but I suspect that you have. Every lab that we order as a provider is something that it adds additional work. We are going to have to, at some point, interpret that lab. And then we're at some point going to have to contact the patient and follow up with the next steps in the treatment plan. And while it should not be the case, providers are very incentivized for this reason to tell you that there's nothing wrong and there's no testing that needs to be done. And so, because if that's the case, that's a lot easier for us. And I would imagine, and unfortunately and regretfully, that that's something that many people in this meeting have experienced. And I believe it's from a good place that it's here, that the physician or the clinician is overwhelmed and they're trying to figure out how to manage their energy and their bandwidth. But it's not okay, but it is the reality of what's going on. So let's talk about how to get labs ordered and how to do that in a way that perhaps this uncomfortable or overwhelmed clinician will be able to partner with you. All right, let's see. I'm going to admit somebody else here really quick. Okay. So here's some tips on how to improve getting testing done. So if there are some tests that you want to get ordered and you're starting to sense that there's some resistance from the clinician that they don't want to order these tests, what you can say is, I understand perhaps these aren't tests that you're very familiar with. Why don't you order the test and then let's set up an appointment and we can go over the results together and figure out what we need to do next. And don't feel obligated to contact me before that. I'm happy to come in. Because here's like a little side note that maybe we don't talk about enough. The only time that a clinician, according to their bosses, the administrators running things, the only time that they're revenue generating is when they're in a room with a patient. So all of our energy and all of our time is dedicated to being in the room with patients. And anything that we're doing outside the room, like following up on labs, calling patients, interpreting things, researching patients, that sort of thing, that's not revenue generating. And because it's not revenue generating, we are not allotted a lot of time to do that. So if you can be there in a room with the doctor so that they're quote unquote revenue generating while they're interpreting these labs, it helps break down a little bit of the barrier of the doctor feeling overwhelmed with having to do that on their own time. So, and then I think for people that have rare conditions or chronic conditions, I think expectation setting with your clinician is okay. And you can maybe say something like, listen, I have weird labs all the time. They may not make sense. I understand that. But we can just come in, we can talk about it together when they come back. Don't feel, if there's something really weird that comes back, let's figure it out. Maybe there's something I can help add to the conversation that we haven't talked about yet. So if there's sort of an expectation that the clinician may not understand the results and you're okay with that, that helps decrease some of the stress with ordering these labs. So that's some tips on perhaps overcoming some of the barriers to ordering specific testing. So the next one is getting treatment. Now this one is maybe really hard because we go through a pretty intense training period, medical school and then residency. And interestingly, a lot of us, that's sort of where our knowledge stops. And we only act on what we learned in that moment of our career. And then, we go to like continuing education courses. So like, a couple times a year, we'll spend a day or two learning some new tips and tricks that we can try out. It doesn't significantly change how we practice generally. So when a patient comes in with a complicated disease that the clinician is not familiar with, and they want some specific training, some specific treatment, there's this huge barrier of getting the clinician to feel safe with that treatment. And this kind of goes back to like, if, our expectation is perfection. And if we engage in a treatment plan that we're not really trained in or comfortable in, and something goes sideways, that could be really awful. So here's something that I'm kicking around, and this is just my thoughts, and I'm not sure if this works yet. But a big part of any treatment plan is this informed consent. And what that informed consent means is that, as a patient, you understand what your options are, and you're choosing to follow a treatment plan. You're not being experimented on, you're very much part of the team. So you can actually start that informed consent process with your clinician. You present some treatment plan, like I want to do a particular physical therapy modality with this physical therapist. And then the clinician's like, well, I don't know about that. That seems weird and whatever. And so you can actually start this and be like, well, so talk to me. So what are the risks of this treatment? What is it that you're concerned about? And they can perhaps voice something. They probably won't be able to voice a lot, especially if it's something as safe as physical therapy. And I say that understanding that probably a lot of you here have had awful experiences with physical therapy, but clinicians generally are very comfortable with physical therapy. But if you go through like, okay, so I understand the risk of this treatment. As a patient, I understand that, and I'm willing to take on that risk too. The clinician can document that, and it sort of takes some of the onus off of them. Another thing that you can do to sort of check the clinician is be like, all right, well, I don't feel good. This is a treatment plan that I'm interested in trying. It seems like you're not into it. What are my alternatives? What else can I do? And, if the clinician can't really come back at you with anything, well, you're sort of at an impasse. If they can't come up with anything better, then it helps them to guide them to this next treatment plan. And then you can say, listen, let's start this out, and then let's follow up in a little bit, and let's see if it's working. And if it's not working, I understand it may not work. And let's follow up and talk about it. And it's sort of that, that gives the clinician this ability to be aware of what's happening, so they're not giving this long, and this is an awful analogy, but giving a long leash that they feel like they're not in control of consequences that could fall on them. And another thing, especially if it's medication, because especially for dysautonomia, finding a clinician that's comfortable prescribing the medications for dysautonomia is difficult. Oh, I'm going to admit one more person here. So you can say, this does seem to help a lot of people. I'm interested in starting this treatment. How about we start on just a very low dose? And you can half pills, you can pour to quarter pills, you can get liquid formulations where you just do a little bit and say, I can just do this much. Let's talk about the benefits and the risks of this. Let's see if it helps. Then we can just slowly go up on the dose. And if you can start really small in a way that the clinician feels really comfortable with it, perhaps they'll be more willing to go on this journey with you. So that's some things that you can try doing to try to overcome this barrier of getting treatment. Okay, now the next thing is getting a referral. This should be so easy. And I don't understand as a clinician why it's so hard. Because you're in front of a clinician, you're in front of a provider who's overwhelmed, not familiar with your case, doesn't know what to do next. And you're like, will you please just send me to someone else? Why is this so hard? And here's what's so complicated about this. When we give referrals, especially as primary care doctors, we get so much static from specialists about what we could have done or should have been doing a lot of times. And I won't, name providers and specialties that especially drive me crazy. But a lot of times we'll submit the referral and we'll get like just like this pre-form letter back that's like, have you tried this? Try this, 6 weeks of this. Have you tried this? Blah, 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 blah. And so all of a sudden now it's like, oh shoot, well now we're tasked to engage in a treatment plan that a specialist has put together that I'm not really trained in, but I have, and I'm now obligated to do it. And so that's one big barrier. Like we don't want to even get close to the specialist because they're going to give us a lot more work. So that's one problem that we have there. And it's really frustrating. And then the other problem is the referrals are often just straight up rejected by the specialist. I worked for an HMO for 3 years and I referred to cardiologists a dozen times, more than that, dozens of times. And I did not get a single patient in to see a cardiologist, not one. They blocked every single one of my referrals. And they stopped even sending me like ideas on how to treat. They would just send me article titles and just be like, read this article to learn how to do your job, is basically like what we got back from them. And so unless you showed up in the emergency room with a heart attack, you didn't get to see a cardiologist in that system. And they have their own barriers. I'm not trying to like talk bad about anyone. And there's wonderful cardiologists. And I'm sure in the system I worked in, they were wonderful too. And they're also, equally overwhelmed. We're all trying to figure out where to put the work. But this is one of the reasons why it's sometimes hard to get a specialist. So as a patient, one thing that can be really helpful is just understanding that this referral process to a specialist can be a process and it can take some patience. And so, what I tell patients personally now is like, I want to be a gatekeeper of nothing personally as a physician. So if you want a referral to a specialist, I'm happy to just put the memo in, right? Like send it over. I'm happy to do that. A lot of times I will get something back. And if I get something back, I just call the patient back like, all right, here's the thing that we're supposed to do now. And once we can check these boxes, the specialist can't reject us anymore. And so you can tell the provider if you're sensing some hesitancy and be like, let's go on this journey. Why don't you just try submitting it? If it gets rejected or when it gets rejected, let's follow up and figure out what they recommend that we do. And we can just start doing it at that point too. And, again, have that expectation, like you don't, and this is unfair a little bit, but like, I will come back into your office and we will talk about why the specialist rejected this referral and we'll figure out what to do next. So if you take off that, like now the clinician is on their own with some, foreign treatment plan and they can talk to you about it and figure it out. That's an idea there. Okay, so lots of information. I'm going to pause for just one more second. Does anybody want to say anything? Okay, wait, there's some things in chat. Let me just see if I can address these. Gotcha. Yeah, that's okay. I'll come back to these chats here in just a second, unless anybody wants to speak up and start talking. And I see this one about what is going on and how do I get around? Let's talk about that one a little bit later, just like you said. Okay, perfect. Okay, now let's go to the next tip that I have. Paperwork. And paperwork is the bane of a clinician's existence, because basically any paperwork that we have to fill out that just gets like dropped on our desk is done during our free time. It's either done during our lunch or it's done when we're supposed to be at home. We don't have any time anymore dedicated to filling out paperwork. That's just not something that administrators are willing to acquiesce. So here's, as a patient, if you have some forms that need to be filled out and you want to get those forms back and not have them disappear into the ether of the EMR, what you want to do is schedule an appointment and sit down with the provider and have them fill out the forms in front of you so that they can answer all the questions on the forms and ask you about it. And then do not trust that those forms are going to continue to exist outside of your hands. So ask for a copy, because we're going to try to scan it. I don't know if any of you have ever been into the medical records department in the bowels of the basement of the hospital. It is cartoonish. There are literally stacks of papers, and we have like 3 people getting paid minimum wage, feeding them into scanning machines to try to get them uploaded to the EMR. It's like 1990. We're just transferring over to digital media still. So if you want to make sure that those papers don't disappear, get a copy and put it in your medical records. I would bet that a lot of you have a pretty good organized medical record of all the stuff that you go through, and keep all of your paperwork. That would be my other tip. So schedule the appointment, sit down with the provider, have them just say, I just need to fill out this paperwork. I will sit here while you fill it out so I can answer any questions that may come up. That's it. And then here's my last tip, is it takes time. That first time that you see a provider, especially if you have a condition that they're not familiar with, not a lot is going to get accomplished. But every time you go back and see them, they get more and more familiar with the condition, and they get more and more familiar with you, and they get more and more familiar with what's working and what's not working. So here's some things to consider. If appropriate, if they haven't done anything wrong, if they're on this journey with you together and you're making joint decision making, let them know that there are going to be treatment failures and you're okay with that, but you want to keep trying new things. And this helps us understand that we're not going to nail it, and we perhaps aren't going to be perfect, and that we're doing this together, and it's okay. Because one thing that really messes with providers is they make a decision and it goes sideways, they have a hard time engaging with that patient again. And perhaps that's appropriate. And perhaps as a patient, you don't want to go back to that provider. I'm not saying forgive providers of all of their mistakes. I'm not saying that. If they hurt you, if they do something really off, don't go back. But if you're on this journey together and you try something, in a safe way, and it doesn't go right, and you don't want to do that treatment anymore, and you still feel comfortable with that provider, let them know that that's how you feel. Like, hey, we tried it, it didn't work. We knew that might happen. And I'm okay. I want to try some new things. I appreciate you listening to me. So that's one thing that you can do. And every time you go back and see that provider, they'll just get to know you better and better and better. So that's sort of all my information that I sort of wanted to share with everyone about all of this. That was kind of a lot of information. So the next thing I'm going to do is I'm going to run in and I'm just going to address some of these things in the comments, and you can all get loaded up with questions if you have some. One thing I do want to say is I'm not in this setting, I'm not anybody's doctor. I will have to speak in generalities. I wish I knew your case to the point where I can give you really responsible and solid advice if you have very specific questions, but I really do have to just speak in generalities to make sure I don't misspeak. So the first question here from Kathy, not one of my doctors ever suggested anything like EDS. Yeah, so interestingly, hypermobility is something that is not well taught in medical school. Surprise, I'm sure all of you are shocked. And so there are a lot of patients that go years and years without a diagnosis. There's a lot of diagnoses like these, actually. Endometriosis is very similar to this, where the average onset of diagnosis from start of symptoms to having a diagnosis of endometriosis is about 10 years. And so one thing that's really helpful when you have symptoms and a lot of things that are wrong is just like to stop the provider and be like, listen, take a minute. Is there something off here? I feel like my life is different than everyone else's around me. I can do this with my wrist, and I'm having these dislocated joints and I have pain everywhere. Let's think about this. But that's hard to do when, you're in your early 20s. And anyway, I wish I had a better example for that. Okay, so patients who are unable to be transported and need telemed are now being told by practitioners that telemed is not available for new patients due to insurance rules. And my insurance says this is untrue. It's not their rule. So what is going on? And how do I get around it? Okay, we as providers, and I personally am terrified of insurance companies. to give you an idea of the power that insurance companies have over our lives as providers, the healthcare sector is the biggest lobbying sector in our government. It's bigger than tech, it's bigger than oil. They spend more money on legislation than anyone else. And the biggest lobbying group in the healthcare industry is Blue Cross Blue Shield. And so, like, I know providers that have had tried to do some things a little bit sideways with insurance and gotten like the FBI on them and almost went to jail. And these are like urban myths that go around among clinicians and stuff like that. Well, I know that particular one is true. And so we are terrified. So if there's even like a whiff of like, maybe the insurance companies won't be okay with this and you're going to be audited and you're going to be out of compliance, terrifies us. Absolutely terrifies us. So the way that you get around this is you actually have to engage with the clinic administrators that make rules and not with the clinician. And the problem is that this telemedicine situation is not universal. Some insurance companies are okay with telemedicine and some insurance companies are not. And it also has to do with where you're located. Washington, it's almost law that you have to have some component of an in-person visit before you do telemedicine. And during the telemedicine, there has to be a visual component to it also. You can't just do it over the phone. So I'm told. I have not researched this in a little bit. This all went really sideways during COVID. A lot of rules got slack, and I think we haven't quite caught up on what reality is anymore. I don't think I even kind of provided any helpful information there, other than that's why it's happening. So that's what's going on. The way to get around it is to find a system that is comfortable with new patients over telemedicine. That's the best I can say, or to engage with clinic administrators and not with the physicians specifically. Okay, so the next question. So what if you're on what's considered an unusually high thyroid medication dose that your labs may not support and you need to change doctors? Oh, this is hard. So do you have suggestions for how to talk to a new doctor about continuing with the same dose? So you found a doctor who understands what's going on with you. You've created a treatment plan that's a little bit outside the algorithm and everything's going great. And now you got to switch. And this is like everyone's nightmare, right? So you're going to have to go to a new doctor and you're going to have to explain to them this weird situation that you have. This is what I would maybe suggest as a physician. So I approach this a little differently than a lot of physicians. I do not believe in stirring the pot. If you come into me and things are okay and you're on XYZ and you can give me some semblance of reality that like you have a pill bottle or something that has a doctor's name on it, and I can find some way to justify that with articles online or anything like that, I will continue it personally. I know that's not how every doctor does it. So when you transition from the old doctor, make sure that old doctor has you set up to succeed with refills or whatever, so that you have months to overcome this problem, because you may have to play a little bit of clinician roulette to find the one that's going to work with you. So that doctor that you found that's working with you, have them help you we can usually do at least 3 months. Sometimes doctors are comfortable doing up to 6 months of medications, knowing that you're not going to follow up with them. That's one way to overcome that barrier. Talking to the new doctor about it, one thing you can do to check them is be like, I'm on this medication, I feel good. And they're like, well, I can't do that anymore. Then you can say, so what are you going to do? Because I need this medication to feel good. How are you going to keep me feeling good without this medication? And if they tell you, oh, we're just going to stop it, like, you just find a new doctor. Sorry, it's a waste of everybody's time. But if they have some other idea and you feel comfortable with it, you can try going on that journey with them and just like, and you know, as we are experimenting with your new idea, I would like to continue on this path and we can, you know, transition. So that would be my suggestion. The biggest part of that is going to be engaging with your old doctor to set you up to succeed. And then there's going to be a certain amount of trial and error to find a clinician, and then check the clinician. It's like, oh, that's not true, or you're making it up or whatever. It's like, okay, well, what are you going to do? this is what worked with my old doctor, and this is what we figured out. Without it, I have these symptoms. So how are you going to manage those symptoms? Or what are you, I'm happy to listen to whatever your plan is, but the plan can't just be, I'm going to cut you off. And that can kind of help a doctor. And of course, do that, like in any human interaction, in a way that both of you are respectful to each other. Like, I understand you're not comfortable with this. What can you do? What would you recommend? So, thank you. Hey, I appreciate that. Oh, great. Okay. So, Carrie says, I've actually been doing these things since they're very similar to having been a teacher. Yeah, these tips are effective. I now have a PCP every 4 to 6 weeks. I really love that. I have a number of patients when I used to work in a big HMO, and they would just schedule appointments with me every 2, 4, 6 weeks. They're like, I don't know what will be wrong, but probably something. And so let's follow up in 6 weeks and let's talk about what we're going to want to do in that moment. And if everything's okay, and I always tell patients, just cancel the appointment. Your clinician's not going to care. They're going to be so grateful. Like, we joke with each other, like, can a guy just get a no-show? Can I just get 20 minutes to catch up on what's going on in my day? So just cancel the appointment, do it, in advance. And almost always it will get rescheduled with someone else. And if not, your clinician will be so grateful to have 20 unscheduled minutes in their day. So I love this, Carrie. That's a great tip. Just make these appointments, even if you don't know what you're going to be talking about. And that way you develop this rapport and this time, and you can kind of just slow roll some of these things that are going on. So I'm moving to Portland. How do I find a doctor who will see me with OHP? Gosh, man. So the insurance situation is bananas. The way that you do, tell you what, I would imagine that probably there's a number of people here on OHP. There is, and I don't have the information on me right now. My wife is a nurse, and her passion is patient advocacy. And she actually has a tool that's been tremendously helpful for patients with OHP, and it's a patient navigator. And this patient navigator generally is good at getting you into the places that OHP covers. Let me find that information. And is that cool if I email that to you, Heather? And you can get that out to everyone? Perfect. Okay. And then A to everyone. This is more of a comment than a question. As a patient, it's frustrating when encountering providers with all these concerns and mental and or systemic barriers who don't voice these concerns, but just kind of shrug and send you on your way. In my experience, I don't tend to tell you that this is how the patient is supposed to speak in order to move care forward. I feel like it wastes everyone's time and a lot of the patient's money. And as a patient, it's so demoralizing and makes medical care feel impossible, 100%. I understand what you're saying about the issues from the doctor's perspective. I don't know, it's just frustrating. I appreciate these tips. It helps recontextualize my own experience to hopefully get me better care in the future. Oh, thank you. There's so much truth there. What we're trained to do in medical school is for a patient to show up, have a list of symptoms that we're familiar with, that we can then diagnose and give you the evidence-based medicine treatment plan. That's what we're taught how to do. And so when we leave medical school and we enter into these encounters where we can't do that, we can't do what we were trained to do, there's a lot of frustration, and more often than it should, and probably more often than not, that frustration is directed squarely back at the patient. There's these terms like medical trauma, medical gaslighting, and all this sort of stuff, and these are all very real. And I guess all I would say is, I understand what I'm saying here might help a little bit, but there's still a huge problem. And this isn't going to solve all of that, and 100%. And there's a lot of truth to what you're saying here. So regarding a new doc, can you have an old doc write a letter explaining how it worked to get you where you are in an in-person appointment, of course? That's a great idea. And I might even take it one step further. I do this for letters of recommendation. Medical students come to me sometimes and rotate, and they want a letter of recommendation. I just tell them, why don't you write the letter? Write everything that you think you're great at. And I'll look at it. If I agree, I'll just sign it and we'll send it off. You can even go into that doctor and do the same thing. Be like, hey, this has been my journey. Can you just sign off on this and say this is true? And I'll take it to my next doctor. And as I've never seen that done before, and I've never tried it myself. As a physician, I would be happy to do that. Be like, absolutely, yeah. Because that whole process of transferring medical records from one clinician to another, is so broken. We get and I just worked at a care facility. I've seen patients in care facilities, and So we would get the hospital discharge notes, and I'm trying to come up with a treatment plan with these hospital discharge notes. So I show up to work, I got a patient who's brand new, they can't talk because of their medical conditions, they can't give me any history, nobody there knows them, the family's unreachable, and I have 160 pages of hospital notes. And I love physical therapists, but about 70% of those are PT notes, which don't help me very much. And so for whatever reason, PTs are amazing at documenting, apparently better than everyone else. And so I've got, 60 pages of PT notes, 40 pages of vital signs, and like a history of when the patient came into the ER, and I'm trying to figure out what to do next. So having something that you've created that summarizes who you are in a page or two, I would love that as a clinician seeing a new patient. I can't speak for everyone, but I think that that would be wonderful. And I don't think it would be inappropriate to write it down, be like, this is my journey, how I see it. Do you agree with this? Would you sign this paper? And the doctor could do that. Or you can do it, like you said, just sit down together and kind of come up with like what's important. And that may be a good question to ask the doctor that you're succeeding with, what's going to be important for my new clinician to know? What would you want to tell them? Let's sit down together and in the next 15 minutes, let's create a document that I can hand off. I think that's a great idea. Okay, so telemedicine. Oh, cool. Someone knows more about telemedicine than I do. I have been writing from insurance. Care coordinator to find a PCP for telemed. Oh, thanks. Great. I will talk to you about my clinic in just a second. I call these through Portland Source, but I think Portland is different. And they assigned me to a new doctor. Yeah. This is pretty, so this is going down to Kathy. The most insurance companies, when you initially sign up with them, they assign you a new doctor. There's nothing magic about that. There's not a lot of thought put into that, and you are not obligated to fulfill with that. I just want all of you to understand that. There's going to be a name. You can try that name out. Often the name's on the other side of town. But if you can find another doctor, you're welcome to go to that other doctor that's better for you. Okay, and then here's some answers to questions, people that know better than I do. Okay, so this next one, we've all heard the don't expect zebras training that docs get, and we as patients with usual conditions have to understand that even though we're living it. The doctors don't necessarily know about it. I mean, I had never heard of Ehlers-Danlos before. Patient freaked out during a range of motion intake. PT, probably not patient, PT, during range of motion intake. So that's the famous saying, right? And I think Ehlers-Danlos is specifically sort of, adopted that moniker of being a zebra. And the saying is like, when you hear hoofbeats, think horses, not zebras. But that saying is really starting to break down because there are so many things with hooves. You got to think about all of them now. There's not just. And so as we are getting more elegant in our healthcare, like what about, we got to think about caribou, and we got to think about elk, and we got to think about all these things. So one thing that I tell patients, like if you hear hoofbeats, so if the doctor thinks they know what's going on and you're not getting better, be like, all right, we tried the horse. Let's try the zebra. The horse didn't get us, it wasn't right. And let's try the next thing. It is pretty crazy. I am hoping over the next little bit it gets a lot better. We're all excited about AI. We're all excited about having access to a lot more information and big data and all that stuff. But there's also this other side of it where we still need to think, and we still need to look at the human being in front of us. I'm hoping that this goes in a better direction than it has been going for probably the last decade, where we do these broad algorithmic, not nuanced treatment plans. I think we're moving a little away from that now. Fingers crossed. Okay, a lot of people replying to the person moving to Oregon. That's great. That's really wonderful support. And new to Oregon, I found DO versus MD are more familiar with EDS. Yeah. And I had a provider in Colorado that was part of a DO residency program, and he was great. Are there opportunities where providers would like to hear from patients and learn more about EDS? I worked as a paramedic as a teaching hospital, and I'm comfortable in the educational setting. I love having baby PGYs asking me questions, post-grads. Is it the best way to spread knowledge? It's a really good question. So if you want to educate clinicians, probably the best place to do that is in conferences. So if you can create a sort of a presentation that could be that you could get continuing medical education credit for, and then get a spot at a conference. That can be a way to sort of engage with this. That would probably be the best way to get a clinician's ear that's not part of a formal training program. And at these conferences, this is very common. We often have physical therapists presenting to us, and we have patient advocates and communication experts and mental health providers that aren't physicians come and talk about their experiences and what we could do as physicians to make things better. So there's a lot of ways to do this. The one that seems like it would be the most effective would be to try to get yourself into those conferences, and that would be to contact like the medical societies in Portland. So it'd be like the Portland Medical Society or the Osteopathic Physicians and Surgeons of Oregon, or OPSO. And then the reason DOs know more about hypermobility, I personally am a DO, than MDs is because as we learn our manipulative training, it's like before we start manipulating people, we learn that you need to make sure that they don't have hypermobility, because you're going to make stuff worse and if you use very direct and aggressive techniques. And generally, I think this is true. I think every osteopathic medical school class has one kid, or one medical student that learns during our osteopathic training that they're hypermobile because something goes sideways. And so they're like, I have a dislocated shoulder, it's not funny, it's sort of funny, it's not funny. They get hurt, and then we all understand how important hypermobility is. And I think this happens more often than not. And then that's how they find out in their early 20s that they're hypermobile. Okay. So Jane, COVID. Okay, big conversation, but are you seeing more post-COVID patients with viral injuries and or laxity issues from cranial nerve damage or inflammation? Seems like so many people I know are telling me that they are having autonomic problems in this new time in response to sequelae from various viruses. So there's another hour conversation that we can have about post-COVID syndrome. It is, and I don't think it's just COVID. The ish that is circulating in the viruses right now is messing people up. This year and the year before feel a lot like when there was that H1N1 epidemic. People just are not recovering like they used to. And it's not just like, honestly, it's not, I don't mean to be, I'm not a conspiracy theorist. I believe in evidence-based medicine. I'm not trying to like stir up any wheels or anything, but it does seem like there's something different about a lot of different viruses this season that is just making it a lot more difficult to recover. And I don't know if it's because we're all so exhausted or what, but it does seem like things are lingering a lot longer. And it does seem like dysautonomia is a much more common sequelae than it used to be. Okay, I tried to keep it to an hour. Gosh, you all listened so patiently. I have a little bit more time if we do want to do some other specific questions. I guess, Heather, I kind of turn the time back over to you, and you can kind of moderate what happens next. Let's see, can I? There we go.
Mute myself. I got close back. Did anyone want to ask any verbal questions while we're that would be appropriate to be recorded, I should say first. And then the other question would be, did anyone want to have me turn the recording off so they could ask questions? Because I could also do that. So
hey Heather.
Yes.
I made a little 30-second thing and a timer. I got chimes. So could you explain that to everybody again really quickly, how we might do that if we do that?
Sure.
Thanks,
Brenda. So if, like, say you wanted to bring up a topic or ask a question to anyone in the group, it could be Ben or just any other people that are present. And it's going to take some explaining. So we'd like to try to keep it to 3 minutes. So Brenda's going to, at about 2.5 minutes, give you the 30-second chime and a little 30-second. So give you one chime and the 30-second image. And then at 3 minutes, she'll give you 2 chimes. So then we're going to try to wrap it up and then move on to the next person. So we can have people, does everybody know how to raise their hand? I actually can't figure it out tonight for some reason. I can't find the raise your hand button on my computer, so. Does everybody else see theirs? Yes, okay. Did anyone want to ask a last verbal question or written question before we take it to just general conversation? And I'll go ahead, Kestrel. Kestrel's thinking about phrasing.
If you want to raise your hand, it's like right about here. If you hover and there's reactions, you can click on that and raise your hand as one of the choices there. It's a little smiley face with a plus hairband or something.
And it might show up differently on different
Oh,
computers.
that's true.
iPad right now, and mine is in the ... If I go in there, I do have the little emojis, and right above that is my raised hand, which I think is in a different place than it used to be. So if that helps.
Kestrel, did you have your, okay. Kestrel would like to know more about the different boards and how they influence prescribers and policies.
Yeah. So this is really interesting. So that's a good question and well phrased, and I'm going to try to phrase a good answer. I interact as little as possible with the Oregon Medical Board. They're sort of like the principal in elementary school. You don't want to go to their office. They don't transparently come out and say you can do this, you can't do this. There was like the last time I saw them do any sort of posturing, and COVID's big, and I don't want to sidetrack this whole conversation, but they did send out some information about what was appropriate to do around the COVID vaccines, and it was liberal. Okay, you didn't say like you prescribe these things to everyone, don't give a shit. It wasn't like that, but they did. You needed to be evidence-based in what you were doing, and if you could support that, it was fine. That's the last time I've gotten any like real specific feedback from them. Now, our training though kind of guides how these boards treat us, and I will tell you, like when I talk with patients, I talk about these different types of medicine, like osteopathic, allopathic, and naturopathic as sort of brands of medication. And there is an unspoken rule that you want to be like on brand with your particular professional societies. I have a ton of respect for naturopaths, and one of the places I have a lot of respect for naturopaths is with thyroid disease. They tend to have a much deeper and a much more open understanding of thyroid disease and be more willing to try some things that allopaths and osteopaths perhaps aren't as comfortable with, because that's on brand for them. So I guess that's how I would say it. What we're taught, we are sort of part of a society, and if we want to stay in the good graces of our society, we can't step out of it too much. I guess that's how I would say it. And it's not something that specifically the Oregon Medical Board has done. It's something that started when we started medical school. That we're part of something, and if we try to buck that too much, it can get us in trouble. Is what I'd say, I guess. All right, so a bunch of stuff just showed up here on the side. If a patient is diagnosed with HSD, EDS, does insurance stop approving physical therapy? Okay, physical therapy. Here's how that works. I should let you talk about this, Heather. This is how I understand it. Heather, tell me if I'm wrong. Insurance has, for almost every benefit, there's like they put limits on how much they're willing to pay, and how many visits for different things you can have over the course of a year. Most recently for me, this came up in skilled nursing facilities. So if you discharge from a hospital and have to go to a rehab, you only have so many days in that rehab that insurance will pay for. And physical therapy often falls into this bucket. The other thing that's really complicated about physical therapy and for the love of God, I do not understand this. A doctor has to say how many sessions of physical therapy you get when they refer you. So they have to say like 1 treatment a week for 8 weeks. And once you get past that, the insurance won't pay for it anymore. So you have to get a new prescription from a doctor who's not trained in physical therapy to send to another doctor that is trained in physical therapy to say how long you're allowed to get those treatments. It's archaic, it's paternalistic, but that is the system. So if you're running out of physical therapy appointments, it may be as simple as just asking for a new referral from your doctor. Does that sound right, Heather?
It depends on the insurance. Some of them are allowing like direct access, meaning you can go straight to the PT and not have to go to the doctor first. So Care Oregon actually allows you to go straight to the PT, like Blue Cross, MODA, Pacific Source. So several of the bigger players are not requiring a physician referral now in Oregon. So that's nice. And then usually what the PTs do is that we'll do our evaluation and then we'll write up what we think they need, send that to a note to the doctor to sign, and then that way it's covered in case we decide like, you know what, I don't think 6 visits is going to get it. We're going to need 12, sign here. So we try to make it super easy for the doctor to just sign that and send it back. And you're right about our notes. It's kind of crazy, like how much we have to write and document is so much more than any other medical provider. And we spend so much time on it's ridiculous in physical therapy. I just figure it's because people come back more than once a week that we really, really have to justify why they're there. I don't know.
God bless you. It's always like 60% of a medical record is physical therapy notes.
It's ridiculous. Anyway. It's totally ridiculous.
This next question about thyroid, thyroid disease. Thyroid disease is really interesting. So let me give you, let's see if I can do this in like, hold up the 30 seconds if I need to, okay? So here's the thought. Allopathic and probably most osteopathics, speaking just of hypo, not enough thyroid hormone. We test for thyroid stimulating hormone. That is the most specific, the most trusted, and the most valuable test to diagnose and treat thyroid disease. That TSH is better than the T4 and T3 because it's been around longer and it often catches problems before T4, T3 are off. And it's interesting why. Okay, but most people and most allopaths don't know this. If you talk to an endocrinologist, you want your TSH to be about 1. That's what you're shooting for. But normal is at, you're starting to hit the normal range at about 5. So if you have hypothyroidism and you get a result back that's like 4.3 and you have symptoms, it's totally reasonable to increase the dose up until you hit 1. You really don't want to go much below a TSH of 1. And this is really paradoxical. The lower the TSH means you have too much thyroid supplementation. This is a whole med school lecture because it's the thyroid stimulating hormone that's telling your thyroid to secrete more. So if it's really low, then that means your brain is not telling your thyroid to secrete more thyroid hormone. That's quick and dirty, sorry. So that's one thing that's really interesting about this is that most providers don't know that it's totally safe, totally reasonable. It's in the textbooks. It's what endocrinologists do if you see them, to keep bringing your dose down to 1 until you're at a TSH of 1. Now, here's something really interesting. And this is why when people aren't getting good care for their thyroid, I personally recommend they go and see a naturopath. There is a second part of this that has to do with thyroid antibodies. One of the reasons that your thyroid stops working is because your own immune system starts attacking it. And you get to a really frustrating place where you are getting your TSH close to 1 and you're not feeling any better. A naturopath will go a next step and they'll order thyroid antibodies, and they will actually start doing things to decrease the thyroid antibodies in your body. I have no idea how to do this. That is off brand from my training. Okay. I don't know what those are, but I do tell people to go talk to naturopaths about it. And here's why. There was a really interesting study that was done in one of the good healthcare countries like Denmark or something. And they found people that had hypothyroidism that was autoimmune. They were at a TSH of 1 and were still symptomatic, and they just removed the thyroid. And so now their body's not reacting to it anymore. And they got a significant improvement in symptoms. And that was a big slap in the face for allopaths, because that's like saying, oh, well, perhaps these antibodies are relevant. We don't know what to do about it, though. Don't come to an allopath to improve your antibodies. We won't even test for it most of the time, except for the initial diagnosis. It's just not part of what we were trained to do. There's also some things that you can do where you can get on T4, T3 combos. That is supposed to be something that you do if you don't have good control. You start adding, in addition to the levothyroxine or the T4, you add T3. This is accomplished with naturopaths with some of the like Armour thyroid or natural thyroid, because it does have both of those in it. We're very uncomfortable with that because it's literally just the weight of animal thyroids that are ground up. So it's not very specific how much actual chemical is there. But we do have pharmacological versions of T4 and T3. And if you can find a provider that's comfortable with that, there are ratios that you can do that can significantly improve symptoms. That was a lot. Maybe we should do a whole hour thing on thyroid because there's a lot to talk about. I don't even know what the question was. Where was that at? Okay,
Had her hand up for quite a bit. Maybe we can pause and get Juliana in and then go back to the chat.
Yeah, that sounds great. What's the, yeah.
Oh, I just wanted to acknowledge you.
Oh, thanks.
Yeah, thank you for your compassion and your commitment to like assisting us. I really appreciate like you being here, like actually being with us.
I appreciate that. I am passionate about medicine. This is my favorite part of my job, is interacting with the patients. And so I appreciate this opportunity to be here too. And thank you. That's super kind. Fills me up. Thanks. You filled my bucket. Thank you so much. So going back, thank you again. And going back to the thyroid question. So prescribers are uncomfortable prescribing medications. Interestingly, thyroid medication is the most diverted medication in hospitals outside of opiates and benzodiazepines, because people will use it to lose weight. So nurses will steal thyroid. So that's why we're a little bit cautious about it too. We do see a lot of sort of sideways activity with it. I do not personally know anyone that's lost their license over prescribing, but I would say if you feel like you're not getting good control of your thyroid, talk to a naturopath. That would be my 2 cents. Okay, so because EDS is so under-recognized in the medical community, a lot of us have to advocate for diagnosis. We have to approach it ever so carefully. Yeah. Why do docs tend to balk when a patient has a good idea and they know what's going on? It's just such a big question, and it's such a good question. Okay, so here's the problem, okay? We are trained, and what we expect when we show up to work is that we're going to be approached as a specialist in the exam room. We're going to go into that room, the patient's going to have a list of questions, and they're just going to be an empty vessel to receive all of our knowledge. And that's a little bit, like I'm exaggerating, but that's a little bit sort of what the expectation is of the doctor going in to see the patient. And that's what we expect as we walk into those rooms. So when we hit a room and there's a patient there that seems to know more about what's going on than we do, there's a lot of different ways that a provider can react to that. And often they react to that as like adversarially, like, oh, well, now I got to teach you that I know what, and that's unfortunately what happens a lot. I am hopeful. I am a geriatric millennial. Okay, I was born in 1981. I'm the last set of Gen X or the first set of millennials, depending on who you talk to. I'm hopeful that my generation of clinicians and younger that grew up with the internet, understand how the internet works, are going to be less they aren't going to put up barricades like the older generation has. Because I tell my patients this, and I know other doctors do this too, I don't care if you Google your symptoms. I don't care if you look it up online. You don't need to be like tiptoe around what you figured out with your research. Google has gotten so much better than it was in 1996 when I was messing around on AOL chat rooms, all right? Like there's legit information there now, and people know how to find it. And so that doesn't intimidate me anymore, because that's part of every part of life nowadays. I mean, like you can't even get on social media without like running into 7 hyper-focused niche experts on whatever you're trying to talk about. So if you're not comfortable interfacing with somebody that knows more about a topic than you do as a clinician, you're going to find yourself not being very relevant in the near future. So I guess my answer to that is I'm hopeful this gets better. That's why doctors balk at that a little bit, is because we expect to be the smartest one in the room. That's what we're trained. That's literally what we're told. I'm the doctor. But there is also this thing, like I was saying before, if it's something we're not familiar with, it's uncomfortable for us, and that discomfort gets translated to the patient. So I hope that helped a little bit. Okay, some more stuff about insurance things. I'm just trying to change. Okay, my range of motion. Okay, so how do I facilitate records going to my new PCP briefly? This is actually something that probably several times a week I sit and I think, how do we communicate better as clinicians? How do we get information from one clinician to the next clinician? So the way that this is supposed to occur is there's a document called the release of information. You can either fill this out at the sending clinician's place of practice or the receiving clinician's place of practice. And because of HIPAA, you have to sign a document that says that you want your information to go from this office to this other office. So it gets to be pretty discombobulated when you have like 7 different offices that you're seeing to try to get all that information stockpiled into one place. I honestly, that's how you're supposed to do it, is you fill out these release of information forms, or ROIs. You can make that part of your visit with your physician regarding paperwork, like sit down and fill that out with them, or most front desks should have them. Is that going to solve this problem for you? Probably not. I am trying to figure out how to create a medical record that a patient could carry around with them from provider to provider, that they could quickly and easily upload into their system, or at least have be easy for the clinician to quickly, glance through. I'm trying to figure out with a format or something on how to do that. I don't know. It's a mess. It's a mess. That's all I was saying.
I'm the one who asked the question. I have my chart. Will any of that, will they be able to just get on my chart, or?
So in theory, so we're just starting to have some products like Epic has one called Care Everywhere. A couple of other systems have something called MyChart. The problem is you can only access a patient's MyChart generally if you're in that same system. So like if you're in Providence, any other provider that you see in the Providence system will be able to access any of the information in MyChart.
Oh, I didn't know that. I thought they could all see everything.
That's,
oh, no.
Because that's what we're supposed to be doing. That was the whole reason we created EMRs, was an interop, but nobody's made it yet. And so that works within a Providence. Now, if you go to an independent provider, like Epic is the name of the platform that we do a lot of our documentation on, the software. So I work in a small clinic. If I wanted to get Epic, it would absolutely bankrupt me. It is so expensive. And I think Harvard switched to Epic, and the price tag was like in the billions. They had to lay off like 7% of their staff to be able to afford this medical records platform. So that's the other thing. If you're going to a small independent provider, they aren't going to have access to anything because they just simply can't afford it.
So basically, I need to do that for every provider, that it can be sent to my new person, which I'm willing to do because I really need like that. I need a new provider, and I need everyone to be on the same page.
Right. What we need is, we actually probably need a new profession that's like a medical records aggregator who puts all your medical records together in a way that different providers, that it will be meaningful to different providers. And that's maybe something that will start happening. One more thing that you can pay for with your healthcare. My wife and I, when we were trying to start a business, that was one of the things we thought about starting. And then we're like chronic people with chronic conditions need one more person and one more bill and everything they're doing. So I'm trying to figure it out. A binder is not an awful idea. And doing release of information with all your providers is supposedly the method that you're supposed to do it.
When I've shared patients with like chiropractors, I'd be like, just have them write on a sticky note, like, and it's nothing legal. It's just like literally a sticky note with the levels that they have finding problems at, and then just hand me the sticky note. And if you can be in charge of the sticky note, we can communicate really well.
And what's amazing You've chosen that because that's more productive and more effective than the billion-dollar software platform that exists.
Yes.
That's how messed up our system is.
Right.
Anyway, 100%. That's great advice.
Or patients, I'll be like, if you can wait, I have my lunch coming up. I'll finish your note. I'll hand it to you. You can physically take it to the doctor. That way, there's no way the fax machine didn't get it. There's no way the person that files it into Epic files it wrong, because they can't even find my notes in Epic. I send them and they can't find them. So I'm like, you need to physically take the copy of it to the doctor, like if possible. So like on your last visit with each of your doctors, like be like, could I please get your summary note? Like, I'll wait in the lobby. So it's done. And like get them to print it and hand it to you. Like,
Yeah.
Can't go wrong.
That's maybe the safest way to do that. The other thing with the ROIs, and this is a really good point, it may not be a bad idea, especially when you're dealing with a condition like hypermobility, where perhaps providers are writing things like patient has a somatic disorder, is a hypochondriac or whatever, and you don't want those notes to go somewhere else. It may not be a bad idea to request your medical records so you can review it before you release that stuff into the medical record ether. I have several patients that have had to unwind diagnoses that have been put on the chart. I'm sure that's something a lot of people.
True.
Yeah. So yeah, that's a good point. It looks like some people have some links. I'll check these out later, of stuff that can do. Yeah, and just keeping track of it. Anyway.
Brenda has a question for you.
Yeah.
Sorry, too many buttons. I was just going to kind of reinforce some of the things that you're saying, just because I've moved a number of times, too many times, but when, and I know it's come up a couple times, like, you know, OHP and new doctors and this and that, and just kind of reinforcing some of the things that other people have said. When I moved here, I did fill out the release forms for my old doctors that I had, you know, in Ohio before I moved here, and made sure that when I went to my new doctor, I didn't want to overwhelm her. And I didn't even know about EDS yet. I just knew that I had been like, a few doctors have been like, wow, you know, like you've got a lot going on. And I'm like, yeah, okay, sure. You know, this is me though, you know, so let's deal with it. So anyway, so I made 4 appointments for a week apart with my new provider. Oh, and OHP did assign me a new doctor when I got here, but I just went on Google and found the highest rated doctor in my area and then found out if they took my insurance. And so I just decided to go to them. Yeah, so I signed up for 4 appointments, 4 weeks apart, and I kind of grouped everything together by importance. And I made lists of not only importance, but things that were similar, you know, and then which referrals I needed when I got here. And I had it like all organized. And I don't know, I felt like I was seeing someone who I felt like I respected her time, you know, in that way, but also didn't overwhelm her as well. And that was really helpful. And also, and I do still, like, when I think of something, I'm like, oh, wait, I wanted to ask my doctor about that. So I'll go into my appointment on my phone, and I will go in the notes section of my appointment and I'll put down the things that I wanted to talk to her about at that next visit. And I will make appointments in advance. I don't know what they're for. I'll tell them, oh, tarsal tunnel syndrome. That's what that next appointment's for, because the person at the front desk just has to make a note of some, you know, and then I get there and the medical assistant's like, so how's your foot? I'm like, what? You know, I'm like, oh no, today we're talking about this, sorry. And then the whole My Chart thing too. Yeah, there are different brands of My Chart and they don't talk to each other. Down where I live, you know, I have my Providence My Chart, which is kind of useless. And then I have my Asante My Chart. And then my doctor has the small, like, My Chart type thing that's from her, you know, business. And she can access the other ones, fortunately, but yeah, they don't talk to each other. So I just kind of wanted to throw that together. And And I really appreciate too, Dr. Burton, that you took the time to meet with us tonight and that you get it. Oh, you know what? Actually, I do have a question. Just a general wondering. Do you think that doctors these days are like overwhelmed by the number of maybe new diagnoses or new things that are becoming more aware, or just being discovered per se? Or is it partly that people are Googling things? Or is it that we just have so many specialists that, you know, doctors who do serve general medicine are just farming out to specialists all the time? Or is it just a combination of all those things? What do you think?
Yeah, yes. So so the first thing, as far as medical information and new disorders and stuff, it was thought when I was in medical school that the amount of knowledge that exists regarding how to treat the human body is doubling year over year. And that's a lot to keep up with. I think now it's going faster. So I hear stories from like doctors that are, you know, reaching their retirement about what they used to do. And there's this little part of me that wants to scream like, well, you had one blood pressure medication, you know, and you didn't even know, you know, no one did surgeries on aortas. That was just a death sentence, you know, and like, it was a very different world. And so there's so much information. And I think a big topic right now in healthcare is artificial intelligence. And they anticipate right now that any decision that a human can make, and I think it's like under 5 seconds or something like that, AI could do. And that number is getting longer and longer. So this idea that you have like a list of symptoms and then I come up with a diagnosis, just like bam, that's no longer a relevant skill anymore. And I think that a lot of clinicians are going to find themselves irrelevant here pretty soon if they're not capable of entering into a patient-doctor relationship where they're not 100% sure what's going on with them anymore. Because all of those quick, easy things like, oh, UTI or asthma or COPD or, you know, broken ankle or, you know, does this patient need a head CT? All of those things can be done now by AI. And it's just a matter of time before that gets deployed. Insurance companies have already started deploying AI, not to help or treat patients, but to check doctors to see if they're going to reimburse them. And so that's happened in oncology. IBM's Watson, somebody started doing that. And so I do think that this is going to get better. I do think a lot of doctors are finding themselves overwhelmed. I do think a lot of old doctors, especially, are finding themselves overwhelmed because the technology is just really blown up. I have a hard time, and I grew up, my dad worked for IBM, and I've lived with computers my whole life. And some of the new technology that comes out, like, you have to be able to learn it very quickly. So yeah, there's a lot of stress right now on being able to manage this landscape. But that's not unique to my profession, though. I'm not going to, you know, don't cry a tear for me. We're all dealing with that, right? In every part of every profession right now. So anyway, yeah, all of those things. So, okay, great question. I hope I sort of answered it. Sorry, I tend to ramble. Thanks. Okay, let me see here really quick. I'm going to scroll back. There was a bunch of stuff. This Corey mentioned this medical binder. And I really like this medical binder. And I think a lot about how to organize a binder, like, because there's something like you can't hack a classic, right? Like you can't break a classic, and a 3-reading binder with all of the information sometimes is what I want as a physician. So I'm trying to figure out, and someday I'm going to come up with a format that's something that a clinician can just like thumb through super quickly and get a gestalt of who this person is in front of them. So but I do really like that one. And then let's see, what do you do if a provider just plain won't get your records to you or the new provider? So this is a really good question. If you're working with an independent provider, there's nobody that is in charge of transmitting records, except for potentially the provider or potentially somebody on their staff. And then here's the really scary part, okay? And this is a hole I myself have found myself in. There are times when your medical records actually don't exist. We get so overwhelmed with all of the work that we have to do that we get really behind on charting. And there are times where we are months behind on charting. This has happened to a number of providers. And so that could also be part of the problem too. One thing you could do is try calling them. I'm sure you've tried calling them. You could see if you could come pick it up. That's a really hard problem. It's a really, really hard problem. You can maybe just ask the naturopath to provide like a summary. Be like, listen, I know it's hard to get all of the records over. Can you, you could do that thing before, like we said, like, here's a page of what I think is important. Does this look right to you? Can you just send this page or sign this page and try doing that to try to hack this medical record transferring problem? Okay, but they're still covering your prescription, so that's great. Okay. Spider diagram, these indicated cluster symptoms into thorax. Yeah. Sorry, I'm just reading along the side here. So Elena Guggenheim, me and her almost intersected with working for Zoom Care at one point. I came into Zoom Care and she was like a local celebrity amongst those patients. And I had the privilege of sort of inheriting a lot of her patients in that realm before she went up to the Hill. And I do like a lot of the ways that she tackles these problems. She's been thinking about these problems a lot longer than I have. And then, so tackling a few things at a time. I like the idea of making a list when you're going in to see a provider, like Brenda was saying. The one thing I would recommend is like, here's my list. What looks important to you today that we should address? And this is what's important to me. And to not come in with the expectation that you'll be able to hit every bullet point on the list. That would be maybe one little thing that I would do. Because if you have like 8 things on a list, the provider will be immediately overwhelmed. All right, looks like Brenda has a question.
I just wanted to add to that, yeah, I will prioritize my list when I go in, and I try to just do 3 things. Like, and we don't always do 3 things, you know, sometimes it's just 1 or whatever, but I try to do 3 things and prioritize my top one at the top. And then if it starts to go sideways, you know, I'll just reiterate that, you know, respectfully, absolutely, but that, you know, this is the most important thing to me today. Like, you might think that it's this, and I get that it's important too, but you know, this is where I'm at. And so, and then, you know, yeah, just having that respect. And then they can sometimes explain like, well, what you don't know basically is that, the reason for this is this, you know, so yeah, so there's give and take there, but I think just prioritizing and then just letting the doctor know what your most important thing is valuable.
That's great. There was a question a little higher up that I sort of passed, but it's like, what can we do to fight against the insurance companies? And man, I think about that a lot, and I don't know. And okay, I'm going to spend no more than 2 minutes on this, but I'm going to go on a journey really quick with all of you about insurance companies and our healthcare. So a lot of people talk about socialized healthcare. There's sort of 3 models. There's capitalism, which is private individuals own the means of production and profit from it. Then there's socialism, where the people own the means of the production and they profit off it. And then there's communism, where the government owns the means of production, they profit off of it. That's really not the conversation. There's free market economics and there's command economics. Free market means that us as individuals, as end users of whatever product, choose how resources are allocated based on how we utilize products. So the more of a product we buy, the more valuable it becomes, and we make more of that thing. And this is supply and demand, okay? That's free market economics. And you can have free market economics and capitalism, socialism, or communism. That can exist. But then you have command economics, where the end user doesn't get to decide, but rather you have some sort of advisory board that's deciding how resources are allocated. So it's not about capitalism, socialism, or communism. Right now, we very much have command economics over our healthcare that's being done with the insurance companies. And I don't care if we find a market solution or if we switch to socialism or whatever, but it's just really difficult right now because as end users of this product, we have very little say in how it gets deployed. And I think about this so much, and I really have no idea what to do. And I am deathly afraid. I am very cautious in how I communicate about insurance companies because it could ruin my life if I piss them off. It's really weird. It's really bizarre. And I'll tell you, I sit and I think, well, I'm like, all right, so healthcare is capitalistic in America. And I ask myself 100 times a day, what is health? What am I selling? How do I know I'm selling a good one? Like, what is health? And I can't figure it out. I don't know. I've asked myself this question 100 times every day for like the past 3 years, especially when COVID hit. I'm like, what is health? And I don't even know what this product is. How do we create an economy around a product we can't even define? It's wild. I don't know how to fight against them. I'm trying in my own little way. I don't have any great wise words about it. I think there's a lot of lobbyists out there, a lot of patient advocates. I know there's lawyers that specifically fight against insurance companies, and I'm so thankful they exist. And I would talk to them about it. I guess that's all I would say. Sorry, that wasn't very helpful. There's my journey. Sorry, thanks for going on that. And I did it, and I think it took me 6 minutes.
Juliana was inspired, it looks like.
Okay, so I probably need to wrap this up pretty soon. I want to just recap really quick. I'm going to send you, Heather, the information about the OHP patient navigators so that can get disseminated. And then I'm going to do sort of a reverse plug for what I do in my clinic. Right now, I'm mostly an urgent care doctor. That's what I do for my day job because it pays the bills. I am trying to start a clinic. It is really hard. We are not prepared to receive a lot of new patients in this moment and do a good job at it. But at a point where we are prepared to really take in a large influx of patients, you know, I would make sure I would let everyone know about that. We're trying to figure out sort of what our next steps are going to be. If you want to hear one more interesting thing, I can't, with what insurance companies reimburse, I can't make the ends meet for my company as a family medicine doctor. So I'm trying to do cash, but that's a huge barrier, especially for people that are chronically ill and can't generate very much revenue. And so that's not going to work. And so we're trying to figure out how to create a clinic that can do this well. Is kind of where we're at. If anyone had any questions about what we're doing. Oh, sorry, I didn't hear that.
Juliana, did your hand go up?
Yeah, it did. For some reason I couldn't hear you. Yeah, I was wondering, I mean, I know some doctors' offices, and I believe this would work.
I'm all ears.
Like have like a payment that people make monthly. So it's like you carry the insurance yourself, basically.
Yeah, no, this is actually, you're absolutely right. It's in that model is called direct primary care. And it is really flourishing in a lot of parts of the country. We are trying to do that model. The insurance companies, I think, have had a big role in what it takes to do this. I have to provide 20 years of employment history with phone numbers and contact information. And I have to have, like, the application for this thing took me like 30 hours and it still got rejected. And then I have to have a business plan. And they didn't like my business plan. And then you also have to have like a nest egg of money so that if anything goes sideways, you can reimburse all of your patients. And that money seemingly can't come from the monthly payments that the patients are getting you. We're trying to figure out how to do this. We have
though, like what's missing?
So the thing that's
like
missing
that
for me.
make...
Oh, sorry, go ahead.
Oh, what's missing that would make it the difference? Like, I mean, I can see a couple of things.
So here's the hardest part about it. for us, for what we want to do, because we do want to work with this complicated community. So direct primary care, like insurance companies, is all about risk diversion. So you have a few people that need to utilize the services a lot when things go sideways, and most of the people need to utilize services very rarely, but are still paying into the pot in case something happens. But if you want to engage with a community that is sort of high touch and needs a lot of interaction with their clinician, the cost has to be like astronomically higher. Because as much as I would like to charge a patient population, like $30 a month, I can't charge that amount if I need to spend 2 or 3 hours even a month on each one of those patients. That's the thing that I'm trying to figure out. So in order to make that model work, that monthly model work, you have to have a lot of healthy, low touch patients, which it can work that way. It absolutely can. And it's an excellent model. And if any of you are interested in it, it's called direct primary care. There are several providers here in Portland that do it. And from what I hear, they're wonderful clinics.
Okay. Well,
it's a great idea.
Yeah, I would love to talk with you more about this. I don't know if it's possible.
I would love to engage more. It's like I tell all of my patients, I wish I could spend all day with you, but there's only so much bandwidth that I have.
I don't know. I'm thinking you need to like what's right there for me is that there could be a team of people assisting you in like the paperwork. There could be a team that's like set for, some of the other stuff that's like standing in your way, and like make it happen. And, I even see like I do this thing. I have a diaper service and there's people who can't pay me. Like they can't afford it. But you know what? Other people contribute.
Yeah. Okay, maybe we will interact more in the future. I'll tell you, okay, I love your energy and I want to believe it. Here's why I'm a little bit jaded. So primary care and emergency care, just to be totally transparent, is a lost leader. Big healthcare organizations have like big organizations like Kaiser and Harvard and Stanford Health and Mayo Clinic. They can't make primary care profitable with all the things that it needs to have, but it's okay because primary care and emergency medicine in a big system is where you capture patients that go to the orthopedist and hit the cath lab and all of that sort of stuff. So we're sort of like the cheap chips at the aisle end.
Wow.
It's you to go down. We're the lost leader on Black Friday. That's kind of our role in healthcare right now because of the command economy that we have that insurance companies are willing to pay. I would like to do this thing where I work with patients that are complicated, and I would like to charge more money for that. I can't even come to the table with an insurance company to have that discussion. They won't even answer my calls. So they basically give me a contract and they're like, here's what, you sign this contract and we'll let our patients come to you. I don't even know how much they're going to pay me. That's not even part of the contract. I don't even know how much they're going to pay me. Heather, you're nodding your head. You know this too, right? Like we're like, okay, thank you. Please give me patients. So I don't even know what I'm going to be reimbursed. And it changes all the time. So it's not even like, okay, now I know how much Blue Cross is going to pay me. No, it might be like $10 less next month. I can't even create financials. Anyway, I could go on for hours.
Yeah.
White burning rage about our healthcare.
Like that's like super complicated that they like control.
Right.
That sounds great. They're like controlling like how people can access healthcare through their insurance and like, oh wow. Okay.
It's crazy. Hey, so much like positive feedback here in the chats and so many people that want to help me.
Yes.
Man, thank you. So wonderful of all of you. And I like that everyone has solutions for maybe some of our problems. I'll tell you what, we do have a website. The name of our here, I'll put the name of our clinic in here. And if you just Google my name, I think it comes up pretty quick, Ben Burton DO. But we're Te Toa Health. Te Toa means strength in Maori, the indigenous people of New Zealand.
Would you be willing to type that in the chat?
Yeah.
So thank
There
you.
Did it show up? I'm trying to, oh wait, hold on. I'm direct messaging somebody. See, I'm a geriatric millennial. I'm still not super savvy with the technology. All right, here we go. There you go. That's the name of our clinic. And then And our website's a little wonky right now. My wife has built that whole website. She had no idea how to do that before. She's also amazing. And she's someone that if you reach out right now to our clinic, you'll most likely be engaging with her because I have to go to my full-time physician day job still. So yeah, so that's our information. If you have ideas, if you think you can help us, I'm all ears because we would love to make this work. I'm going to keep having faith. We're going to figure it out, right? We've been at it for about 18 months, so we'll see what we can do next.
Yeah, complicated patients. They generated a complicated, a not complicated, and a medium complicated evaluation for physical therapy a few years ago. And they were supposed to pay us differently. And we just looked into it to see if we're actually getting paid less for the complicated patient by 1 penny. That makes no sense.
Do you know in emergency rooms, I think it's Aetna, just don't pay. Like if you bill for the highest level, they just won't pay. They just deny all of them. It's so wild. It's wild. So anyway, yeah, it's because I've thought about that too, like billing at my high. So in healthcare, you can bill at different levels and you can bill like time modifiers. It's super complicated. But you can bill at a higher level, but it turns out they actually aren't reimbursing us more for that. So frustrating. Yeah. Okay, yeah, if any of you want to send some information our way with ideas that you have, if we can engage, we will. I want to say, if you do that, thank you, and I appreciate it. If we don't get back to you, it's not because your idea is bad, it's because we're trying to figure out how to make it work. I really do respect all of you, and I do think you probably all have great ideas, and I'm if we can find something, that would be great. Great. Okay, I think that's probably all the time I have. Are there any other burning questions that anybody wants to ask before I take off? And then Heather, do you want a copy of that PowerPoint to send out? I don't know if it's super helpful. Okay, I'll send you a copy of that. Cool. Hey, thank you so much, all of you. I appreciate it. As a family physician, I'm always a little bit nervous entering into a community, a patient community, because I know that there's a lot I don't know. And you all been super kind and super generous and with your time and with your positive feedback. So thank you so much. That means a lot. And I'm gonna take up. Thank you so much.
Thank you.
Yes, thank you.
Thank you.
Go for it. You can jump in. It looks like nobody's got their hand up. So if anyone has a question they want to pose to the group at large or anything else you need support on, we've got a few more minutes, about 10 more minutes left.
I'll offer.
Sorry, go ahead.
I just got my first CPAP machine a month ago. Yeah. I put out there that the ResMed machines, the filter that's on them is just a basic pollen and dust filter, but mine is called a Luna, like the moon. And it has a beefier filter on it that helps to filter out viruses and bacteria. Just thought I'd just put that out there for anybody who wanted to know that.
Thank you. That's pretty awesome. You said Luna? Thank you.
Anyone had problems with air swallowing with their CPAP or BiPAP machines and come up with a solution for that? Struggling with air. I had to switch to a BiPAP to have less pressure constantly. Like it releases the pressure on the exhale because it was just shoving air into my stomach instead of into my lungs. I'm very resistant to taking air in, apparently.
Can I ask a question? I'm kind of new to coming on the Zoom meetings, but recently I had something that used to just happen once in a while. Now it's happening every night, where I wake up completely dry mouth, lips all cracked, gasping for water and air. Is that something someone else goes through?
That can be a sign that you're having sleep apnea and you're trying to breathe through your mouth because your nose isn't
Yeah,
allowing
I'm
the air to
waiting
pass.
for a sleep study, but it takes forever, I guess, for them to send me the stuff. And then she said it could take a couple months for everything. So
Do you know if you breathe through your mouth? Do you have nasal congestion, Pamela?
I do a little bit more right now. I think I have a little bit of a head cold actually, but when I fall asleep, I'm like, air's trying to escape through my mouth like a puff, like I've stopped breathing or something.
Mhm.
I
That's
feel
You
like
know-
I'm almost stopping breathing.
Yeah,
Yeah.
Brenda, do you have comments on that?
I was just gonna say it turns out there's a lot of different kinds of sleep apnea. I didn't know anything about it. I don't know if I learned about from this group or another group, but central sleep apnea is when you stop breathing. It's when your brain doesn't tell your body to breathe. And one of the signs is waking up gasping for air. So it could be central sleep apnea, definitely something to ask them about. And apparently you can develop central sleep apnea from being on a CPAP machine as well. Yeah, just some things.
I was gonna call them and say, you might want to hurry my appointment along if you can. Because I'm not feeling, not getting enough sleep is like killing me.
Yeah. You can ask them to put you on like a cancellation list. And I know when I did my sleep study, I had to have a COVID test, but they would even do the COVID test the same day as the sleep study. If you're coming from out of town or something like that, because I live in kind of a semi-rural area.
Yeah.
Yeah, and people come from hundreds of miles to come here. So anyway, yeah, so just maybe give them a call and ask if you can be put on a cancellation list.
That's a good idea.
Do any of you have warnings before your muscles go into spasm other than feeling it right before? I've been hitting my limit a lot lately physically, and it's really difficult.
Mine doesn't give me much warning. I just know if I overdo it, it's gonna happen. I think I can do something, and then my one physical therapist said, don't walk more than a quarter mile a day, because I've gotten stuck a few times not being able to walk.
That's scary. Yeah, I'm getting the same thing.
I found that
It'll be like I didn't have enough magnesium or enough fluids. So if you know that you've been bad about drinking, that might be something preventatively, get your electrolytes and fluids in and hopefully cut some of those off.
Most don't get enough magnesium.
Yeah.
That's your doctor levels for sure.
Anybody else using CBD and having good results with it?
I got some free gummies from someone, some edibles. And I talked to one of my friends, because I really don't like the feeling of that. But she said her mom, who was dying